Okay, good afternoon, folks. We're going to get going. Again, thank you for joining us this afternoon at the first of what will be a monthly webinar series, at least monthly. We'll be doing these presentations on various topics that speak to the goals of the IDN and their work to develop integrated care approaches that enhance quality of care and lower cost of healthcare. My name is Joe Vijay, and I work for IDN Region 7. I'm the organizer of the IDN webinar series, and I'll be hosting today. Before we get to the presentation, just a few things we wanted to touch on. First, we will be offering continuing education credit for today's webinar. And as a result, we have the following disclosures to make about the planners and the presenters of the webinar. So those are there for your information. The webinar is also being recorded, and that will be available on the North Country Health Consortium's YouTube channel. North Country Health Consortium is the administrative lead for the Region 7 IDN, and we'll host our webinars, recorded sessions at their YouTube channel for your reference after. And there'll be some more information about how to pursue the CEU information for our partner organizations at the end of the slide deck. The learning objectives today were in the pre-webinar information, but here they are again, and our presenters today will be working through these various topics as they present on best practices for patients with substance use disorder, reducing stigma, and understanding multiple pathways to recovery. We're excited today to have Corey Gately and Daisy Pierce with us, and we'll be starting the presentation shortly here. We did want to ask if you have questions during the webinar, if you could enter those into the webinar chat function, the Zoom chat function. We'll moderate those at the end and get you answers to those questions. That would be great, so we can keep the presentation flowing. So with that said, I'm going to hand the presentation over to Daisy and Corey. Thank you very much for being here today.
Joe, I did try to forward the slide and it didn't work, so just we'll do our intro again. Sorry about that. So I'm Daisy.
Okay.
The Executive Director of Navigating Recovery.
And my name is Corey Gately. I'm an MLADC, and I'm the Clinical Program Coordinator of LRG Healthcare's Recovery Clinic, which is a medication-assisted treatment program, and we'll talk more about that as we go.
So the work we're presenting today started with a grant from the Foundation for Healthy Communities, and that grant allowed us to partner our local hospital here and the Recovery Center by placing recovery coaches in the emergency department. We respond on call 24/7 to any overdose survivor, and we'll explain that partnership more later in the presentation. Joe, could you slide? Yeah, thank you.
There we go. And it's probably important to mention that our partnership was what created the need for this kind of education in our hospital, because when we started to partner and we started putting recovery coaches in our emergency department on an on-call basis, we realized that our hospital staff and everybody who was involved in working with the folks that the recovery coaches were getting to work with, that we had some serious work to do around reducing stigma. And so that was the idea that we developed out of having the recovery coaches in the ED. So we'll talk a little bit more about that, like we said, as we go. It's really important for us to understand, first of all, though, what substance use disorder really is. We have to understand the disease. And on the slide that you're seeing in front of you, on the left, we have a healthy brain, and on the right, we have an opiate-dependent brain. And that's about 7 years of use. And one of the things that I really like to make sure people understand is that what you're seeing there is a certain amount of brain damage. And it doesn't mean that people can't get back some of that and gain back the function that they've lost, because that can happen. We know that neuronal connections can get fixed, for lack of a better term, in recovery. But what we're seeing there is what the brain of someone might be like when they first come to us and are asking for help. And so I always like to make the point, before we talk even more about specific definitions for substance use, that when someone comes to us for help, we are generally asking them to do lots and lots of things, like call counselors, call treatment centers, repair families, take care of their health, and do lots of things that folks would have a difficult time doing anyway. And we're dealing with some amount of brain damage. And so it's an important piece for us to recognize that our patience level and our understanding of what's happening for people when they come in and ask for help is huge. So what we know is that there's two types of dependency. One is the physical dependency, which is the biological dependency that becomes the new norm for that individual. And the second is the psychological dependency, which is really the emotional dependency that becomes biologically reinforced. In other words, there's emotional discomfort and there's the sort of the fear of withdrawal if they didn't use. And substance use disorder is a medical mental health diagnosis which requires both the physical and psychological dependency criteria to be met. And there are a lot of medications that people can be physically dependent on for a number of reasons. And we'll use a lot of these examples today. Things like diabetes, high blood pressure, asthma, and you've probably heard a lot of those examples before. Those medications may not be addictive medications without they are not addictive medications without a psychological dependency. And on that note, someone can take a medication such as OxyContin, which is known to be highly addictive as it's prescribed for pain, and they can maybe not become addicted for the same reason. Substance use disorder is the correct term now, not just for reducing stigma, but because alcoholism and drug addiction are too specific to just the physical dependency and do not encompass the psychological dependency that goes along with it. Now we even have an SUD continuum, which helps us a lot in our diagnosis of the folks that we're seeing, because the DSM-5 gives us levels of criteria in order to diagnose someone. And I think that helps a lot. Daisy and I spend a lot of time talking about how people can come to us at all levels. And we used to have this idea that people needed to sort of hit some rock bottom place, and it needed to be a really ugly place that people got to. And today we are much more open to the idea that someone can get well long before that. And the new criteria in the DSM-5 help us with that, because someone can meet a few criteria and we can say, no, they don't have substance use disorder. They can meet 2 or 3 criteria and we know that it's a mild substance use disorder. And so that criteria helps us to deal with patients in a much different manner. Okay, so this is, I'll be honest with all of you, this is my first time doing a webinar. I usually draw this picture on a whiteboard and I spend time erasing. And so, wow, it looks confusing up there. I'm gonna talk through some of these pieces. This is my personal art. So this is the first time I think I've had my art really displayed on the web. This is great. This is 2 neurons in the brain that are communicating with each other. And so here's what happens in our brain. One neuron has to send a message to another neuron in order for us to think. And this happens all day long for all of us. It's a process that the brain fires messages like electrical synapses, which you've probably seen pictures of and diagrams of. And so one neuron in this picture creates dopamine, a feel-good chemical. And that neuron sends the dopamine to another neuron, which is the receiving neuron, and the dopamine comes down through the synaptic cleft and sits on the receptor sites of the receiving neuron. And so that feels good. And the thing I want you to keep in mind is that would be like if you're having a conversation with a coworker and you guys have a good laugh about something, or somebody came in today with a fun Halloween costume on and you just laughed out loud. Dopamine would be released from one neuron. It would go down and sit on the receptor sites of the receiving neuron, and that feels good to us. So the next piece in the next slide, it's going to be a little bit of the similar slide, but what I want you to see is when people start using substances, there are several things that happen. First of all, the dopamine in the first neuron starts to diminish. And one of the reasons for that is because when you put an artificial substance in, it's like having 2 keys that fit the same lock. And so your brain gets the message when you start using substances that it doesn't need to make as much of its own feel-good chemicals because you're giving it what it needs. So I X'd out some of the dopamine in that neuron because that dopamine is starting to sort of die off, for lack of a better term. And let's see what happens when someone takes an artificial substance is there's not enough receptor sites on the receiving neuron to accommodate the substance. So our brain does this very clever thing where it creates more receptor sites so that it can accommodate the substance. And those receptor sites, what I want you to picture is, if I had a whiteboard in front of me, this is what I would do. I would go ahead and erase all of the substances on the receptor sites so that you could see that we originally had a few empty receptor sites when your coworker came in with a funny Halloween costume and the laugh was over. Hope that makes sense so far. Now, if you take the substance, when the substance wears off, you probably have, 3 or 4 times that many empty receptor sites. And so the concern there is that when you have all those empty receptor sites, your brain is probably screaming to have them filled. And when we only had a few and we weren't used to having artificial substances, our brain wasn't asking for any of those to be filled. So there's not only less of our own feel-good chemical production when we use substances, but now there's more receptor sites that are looking to accommodate and get those feel-good chemicals. So when someone doesn't have them, they sort of naturally feel a level of depression and probably more anxiety and are really, really wanting to fill those receptor sites. So this slide as well, this is one that I usually do on the whiteboard as well, but I want you to see the line that goes across the page is, I hesitate to use the word normal, but we usually would like to say that line is like the standard for where someone's at. And the first peak, and the reason that we have a little squirrel there drinking coffee is because I always use coffee for this example. And if we have coffee drinkers in the audience, you can maybe use your own history of coffee use to understand this slide a little better. If you hadn't had coffee or caffeine and you started using caffeine, you would probably find that it spikes up to the top of that first spike. But if we're honest, we know that it dips down below normal when it wears off. And over the course of time, now this graph might be over the course of days, weeks, months, or years, depending on the substance. But over the course of time, we find that the substance, we'll talk caffeine for right now, doesn't give you the same feeling that it gave you before. And when you dip down, you actually dip down even further. And over the course of time, if you follow that through, you'd find that eventually someone's using coffee just to feel normal, so to speak. And again, if we take that even further, you would see that a lot of the time people aren't even getting to that place with the substance. So if we go back and we like substitute a different substance in here, you could say that when someone first uses cocaine, it gives them a certain high, but they crash down low. And then over time, they don't get quite as high, they crash lower. And again, follow that all the way through and you would find that eventually someone using that kind of substance might say, I'm using just to feel normal. And this is what they're referring to. So tolerance and how it makes them feel. Aw. So these are, the dog on the right is Daisy's dog. And the 2 dogs on the left are my 2 dogs. So Callie and Justin are on the left. I forget what your dog's name is.
Oh, Millie.
Millie, that's what I thought, Millie. I don't know why we both have black dogs, but we do. And so the reason that you're seeing our dogs is because this is one of the examples that I use when we talk about substance use is when you think about dogs, we probably are all pretty familiar with Pavlov's dog, right? And if you ring the bell and give the dog meat, ring the bell, give them meat, and you do that over and over again, eventually they know that when the bell rings, they're getting meat. And one of the reasons that I use this is because I like to explain to my clients that when they have that kind of connection with the substance, oftentimes they are triggered by things that they may not even recognize they're triggered by. And so the example I've always used with my own dogs is if they hear something that they think sounds like like a wrapper, they hear something that sounds like a stack of Ritz. It might not be the bag of bones, but we were opening something else and it sounded like bones to them. What happens is they generally come flying around the corner and they start doing probably all the tricks they know to make sure that they're doing what I want them to do to get a treat. Now keep in mind, they only heard a sound. That's all that triggered them. And while they're sitting there, the important part to explain to our clients is that While they're sitting there, they're having a physical reaction to the sound. So they heard something, but their brain sent a message to their belly. Their belly started churning chemicals because their brain told their belly to churn those chemicals because they're starting to get ready for a treat. The chemicals are then coming up their esophagus and it's causing them to drool. So as I tell everyone, they're not drooling because I think that's cute. They're drooling because their body physically reacted to a noise. And that's what happens with our clients. They hear something, they smell something, even seeing something, and it creates a very physical reaction in them that is unavoidable. And I think if we all look at our own lives, we can probably say the same thing. I might not have been craving French fries, but I drive by McDonald's and suddenly I'm saying, ooh, I'm hungry, or ooh, I really want that. And that craving level is something that's important for us to acknowledge. Our clients who use a lot of the substances that are out there today are feeling that on a scale that we can't even imagine. Very, very different than what our cute little dogs are feeling.
And the reason I've got Millie's picture up there is because I learned something about myself by having her, which is apparently I swear when I drop food in the kitchen, because now my poor dog, every time she hears a swear, comes running into the kitchen, even if it's just because I stubbed my toe or forgot something on the grocery list or whatever the reason may be. She is now in the kitchen, frantically searching the floor, salivating, and having this physical reaction to something that was just a word I said that has absolutely nothing to do with food. But because of that, I learned that I swear too much in the kitchen. Okay, so why are drugs so effective? As Corey described, when the drug binds to the receptors, a signal is sent to the dopamine terminal to release more of the dopamine. But when you're using a drug, it's 2 to 10 times more dopamine than with a natural reward. So if your coworker tells a joke and you laugh, that's one set of dopamine that's released. But when you're using a drug, imagine that euphoric feeling being 2 to 10 times stronger. So it creates a feeling of bliss way beyond what our brain chemistry would normally allow us to experience. So with 2 to 10 times more dopamine in the system compared to natural rewards, it doesn't take long for one's hierarchy of needs. If you're familiar with Maslow's hierarchy of needs, that can be rearranged pretty quickly to place the incredible feeling of euphoria at the top of the list. So as people build a tolerance to the drug, the brain doesn't produce enough natural dopamine, as Corey described, or even other neurotransmitters like endorphins and serotonin. But the drug doesn't produce enough either. And so the individual keeps increasing the amount they use to try and reach that same feeling, which is why you can hear people refer to chasing their first high. So drug use also impacts the hippocampus, which is the part of the brain that's associated with memory, and the amygdala, which is associated with emotions. So people then have positive memories and feelings with drug use, and hence that psychological dependency that Corey mentioned. So with opioids in particular, as a person begins to use the substance, sometimes it's for psychological aspects. We refer to that as self-medicating, or they could have been prescribed it for pain relief. So they then quickly become physically dependent on that drug. And then the high isn't the appeal of continuing to use anymore. It's actually the fear of the withdrawal symptoms. Because as they say, withdrawal with opioids, you're going to feel like you're dying. You're going to want to die. It's awful. But with alcohol, you have to be aware that you actually can die from withdrawal. So the way an overdose happens is when the tolerance to the reward system develops faster than the tolerance to the suppression the drug has on the body. So it's important to keep in mind that opioids and alcohol are in the depressant class of drugs, but this doesn't mean that they lower a person's mood. In fact, many people say that their mood is improved with drug use, which is why a lot of people will use it as self-medicating. So depressants, other ones would be sedatives or tranquilizers. They actually slow down the activity in the central nervous system and the respiratory system. So it's the slowing of these systems that's responsible for the person to almost stop breathing and the heart to almost stop beating during an overdose. So when an overdose is happening, first the breath starts to slow. The opioid works on the system that controls both sleep and breathing. And so that slowed breathing occurs with the ingestion of the drug, and it becomes dangerously slow, and it can lead to a complete stop. And then the heart rate slows as the opioid suppresses the neurological signals, and the oxygen level then falls low enough that the heart starts having abnormal rhythms. The heart is not beating properly, and at this point, some overdose patients do have sudden cardiac arrest.
So I'm gonna add to that just briefly, because I think one of the things that we will get to as we talk about medication-assisted treatment is that inducting MAT in an emergency department is a significant piece of this, because when people come in and tell us that they're deathly afraid of withdrawing, very, very afraid of the pain that comes along with withdrawing, and they find out that there's a solution and a way to have medication-assisted treatment immediately, we find that more and more people are starting that treatment right away. The pain of withdrawing is because they've become familiar with what those withdrawal symptoms feel like, but they may have also changed pieces of their brain, their opiate receptor sites in their brain. And we know, there's a lot of research that's been done on the fact that over the course of time with someone using opioids, they may actually lower their ability to handle pain. So somebody may have had a higher pain tolerance, they lower that over the course of time, and it makes it even scarier to come in and ask for help and know that you're going to have to go through that. So this next slide, how New Hampshire compares nationally. So we're in the dark red category there. I'm sure all of you out there know that we're in the highest rate of opioid-related overdose deaths in the country. And we know that in 2016, there were 437 opioid-related overdose deaths, a rate of 35.8 deaths per 100,000 persons, which is nearly 3 times higher than the national rate, which was 13.3 deaths per 100,000 people. And from 2013 through 2016, we know that opioid-related deaths in New Hampshire have tripled. And so those numbers had continued to rise for a long time. We are now just starting to see that that's leveling out a little, but there's several pieces that go along with that. One is that they say that the amount of Narcan we've been able to distribute and have out there has helped a lot. Although those numbers are even hard for us to tell because we're not always hearing. I mean, people may have Narcan and may have used Narcan and may have saved someone's life. It doesn't mean that they called an ambulance and we knew about it. So there are some speculation out there that that's helping to a certain degree. We also know that medication-assisted treatment is helping, but bigger than all of the other things that may be helping is the fact that we have crystal meth on the rise, and we know that there are a lot of people who are switching to that drug or using that drug even more, and there's a lot of it out there. We're all starting to really feel the effects of seeing folks who are using crystal meth. And we're not seeing that there's not a lot of overdose deaths because of that. So it may not be all great that the numbers are evening out because we're seeing a lot of difficulties from that drug.
So what is stigma? A lot of what we're trying to achieve with this education that we provided at the hospital was reducing the stigma that's associated with substance use disorder. So we probably all want to believe that we are not discriminatory, but using stigmatizing language is actually a form of discrimination. So a person with a substance use disorder, it's important to remember, has a medical diagnosis. So when we treat it that way, we increase their chances of getting the help they need. And when we treat it that way, what we mean is using language that is congruent with recognizing it as a disease, as an illness that needs compassion and care, and not as a moral failing. So patients may stigmatize themselves. I'm sure anyone who's worked with patients in this population recognizes that there's quite a bit of self-shame and embarrassment that comes along with having this disease. So we don't need to reinforce that. They have that on themselves, and it's actually our job to use language that's appropriate to help them recognize that it's not a moral failing on their part, that they do need help because it is a disease. So stigma, being an attribute or behavior that's socially discrediting, I think we can all agree that at this point, substance use does have that social discrediting reputation. So it's important to recognize our own biases also when we're working with patients in this population. Everything we've known over the years has kind of shifted now that we have that continuum of SUD and really do know it to be a medical and mental health diagnosis.
Daisy and I spend a lot of time talking about how we do this education. We've done this education a lot of times. We spend a lot of time talking to people in our community and in our organizations about using language that isn't stigmatizing, and yet we will still catch ourselves at times using a word that we've used for years and years and years. So I always like to acknowledge for everyone that changing your language is really hard, and it may take a while. It takes practice.
There we go. So language facilitates our communication, and it's what allows us to understand each other. It's really what makes us human, right? We have this language that we can all use to communicate. So it's important to know that the words we say have an effect on other people. And I want you all to just think about anytime someone has used a term that you find hurtful or offensive. I'm guessing that it doesn't make you want to open up to that person or be vulnerable in front of them and then ask that individual who used that term that hurt you for help. So that's why stigma is the #1 barrier to someone waving the white flag and saying, I need help with my substance use, because if they have heard you use language that hurts them, you're not the person that they're going to want to open up to and be vulnerable in front of. So in order to help someone who's struggling with substance use and to destigmatize this, we need language that's unified. And so, Corey just mentioned we do struggle with using the right terms all the time because, even though we do this every day, it is a shift for us as well. But we do have to recognize that caution has to be taken, especially when we're working with disorders that are heavily stigmatized, such as substance use disorder.
And one of the things I think that bears mentioning is that for all of us in our organizations, we may find that we're struggling to work towards dealing with this as the medical illness that it is, because our system doesn't always allow us to do that. And the example I ask you to think of is if, let's say in a hospital situation, someone comes in and they're newly diagnosed diabetic, we may be doing lots of different things to help them get the referrals that they need and get to the places that they need to be and go to the specialist. Oh, I guess we were muted for a second there. I'm not sure which part of that you may have heard. So I want to make sure that we're looking at the medical illness in the way that it really should be. And I think part of the problem that we have is in a lot of our healthcare organizations, we do a lot to help people with a medical illness when they're first diagnosed. But a lot of the time what we're doing with folks who come in with substance use disorder is we're putting all of that responsibility on them. Here's a pamphlet, here's the numbers you can call, and we're making it very, very difficult for them to do what they need to do as a next step. And so I want to recognize that a lot of the other medical illnesses, we do a whole lot to help people get to the next step. Joe, if you can hear us, we're having trouble. Oh, there it goes. We got it.
Okay, so what do we say instead when we talk about language mattering and how we should frame our words to be destigmatizing instead of stigmatizing? We encourage people to say person with substance use disorder because we want to recognize them as a person first and that it is a disorder they have. So we avoid using the word addict, junkie, pill seeker. And although you may hear patients refer to themselves with those terms, that's on a choice that they can make. But for us, it's important to say person first. When we talk about someone who's using, or when they have a drug screen, we like to say it's abstinent versus clean. And that's in part because a lot of the women in particular that we work with have experienced sexual trauma in their past. And it's not great when we refer to them as clean or dirty. And so abstinent is the term we prefer to use when someone is not using substances.
Yeah, and we like to make sure that we're looking at their drug screens. I always work with our staff on saying that their drug screen is negative. or it may be positive for one thing versus clean or dirty. And if somebody is using, we would like to be using the terms actively using instead of positive for substance use, or I mean, in addition to positive for substance use, instead of saying you had a dirty urine or you're dirty today. We try really hard to stay away from that language.
We also like to speak of people as being a person in recovery or someone in long-term recovery versus recovered addict. This is in part, one, because we try not to use the word addict, but two, because this is a lifelong, chronic, relapsing brain disease. So although someone can live the rest of their life in recovery, they are working at it every day and will have to continue working at it every day. They are not ever recovered.
And my passion one here is the medication-assisted treatment versus opioid replacement. And we often hear a lot of stigma around medication-assisted treatment today, and not even just so much versus opioid replacement, but when we hear people say someone who comes into a Suboxone clinic is just switching one drug for another, and it really bears talking about, because what we see, this is the example I use. I had a woman last year who came to us, and she was with us for quite a long, or she's still with us actually. When she first came to us, she had no home, had lost her children, did not have a vehicle, no job. And her family was really done with her. And she was sort of the picture of what we often see when someone's reaching out for help. And 4 months after joining our program, she was actively in counseling, because people need to be if they're in our program. She was receiving her medication from us and doing well, attending appointments, had secured a job, was reunifying with her children, had worked on her family relationships, and had her own apartment. So she came to me at the 4-month mark and said, I really want to come off this medication. And I said, that's, you're in the driver's seat, of course, but let's talk about this. And she said, my boss told me that I was just switching one drug for another, and my family thinks the same. So we had to have a big conversation around that. And I think it's unfortunate that we're seeing people who are stopping some of their treatments because people see it as switching one drug for another. And my only feedback to her was, if you had switched one drug for another, I don't think you'd be the changed person that you are today in 4 months. And so switching one drug for another is switching from heroin to cocaine, or cocaine to alcohol. And you all know what I mean by that. We have to stop that stigma around the fact that someone is now taking a medication for a medical illness, and being made to feel like they're just switching one drug for another. And we treat a lot of diseases out there today with medication. When we see someone newly diagnosed with something like diabetes, we say, here's the treatments you can do, here's the behavior changes that you may need to make, here's the medication that's going to get this under control and help you. And we also say, somewhere down the road, we may be able to take you off this medication based on some of the behavior changes and the way your life changes. We also tell them we may not. You could make all the behavior changes possible, and we may not be able to take you off the medication because of the medical illness that you have. And I think the same holds true today for what we're looking at with medication-assisted treatment. We have folks who will come in and stay with us for a long time on a medication, but we really have a vision that we need to change. We have a lot of sort of stigmatizing experience, unfortunately, with MAT in our system at this point, because we are doing MAT induction through our emergency department, and we do have an MAT clinic in our hospital. And so we're hearing folks telling us that we're just giving out something that's, helping people to switch one drug for another. And we're hearing that in our own systems. So it's for sure a process to make sure that people are educated about how these things work.
And so this is where another place we want you guys to recognize your own biases, because the words we use reflect where we're coming from and how we view that person. And so if we start to view the person as really needing compassion and care because of their disorder, we're going to say that they're a person first. And we're going to stop using terminology like dirty or, pill seeker or junkie, because those are coming from a place of distrust and having a negative view on the disease.
Okay. So engaging people in treatment. So one of the things that we know is that, again, I want to reinforce the fact that this is a medical diagnosis. I think we've said that 6 or 7 times. But when we treat it that way, we know that we help to encourage people to get the treatment that they need. And so I'm just going to read through this slide because this is important stuff. Studies show that when we engage people in treatment resources through our emergency department, we give them a much better chance at long-term recovery. There was a Yale study that showed that 78% of people were still in recovery at the 30-day mark after being connected through their emergency department. Otherwise, our particular system, we were seeing less than 25% of people follow through. And so one of the things we know is that helping our ED staff to really understand how to get people connected and what they can do. We did this education, and we were lucky enough to have a hospital organization that made it mandatory for many of our departments. And so we did the whole education. Daisy and I taught it probably 20 times, I think, to a bunch of different groups of people. And we had one of our local fire department folks come back to Daisy and say, wow, something was really different in the emergency department when I was there last week. And he really sensed the change in our staff and how they were treating folks. And I think there's a lot of upsides to having resources that people can connect to through our ED. And we may all know that, but we may not all have those resources available. And so one of the upsides for us has been having our staff feel like they have something that they can give to people. I think a lot of times what our staff was feeling was like they didn't have anything that they could actually do. Very frustrating situation for them to be in, to have people coming in and asking for help. They first of all weren't able to not stigmatize at that time, using language that was stigmatizing, and not able to use the resources that were out there because they did not know how to connect people to them. And so having recovery coaches in our emergency department talking to people not only meant that our patients got to have a level of care that was different for them, but it also meant that our staff got to talk to the recovery coaches and even the family members that were there with the patient. So it's been a really positive experience for us to have recovery coaches in our emergency department talking to people. And it's also been a very positive experience to have medication-assisted treatment induction through our emergency department. And we can talk more about that as we go, because oftentimes there's a lot of questions about how we managed to make that happen. But that's been a really positive experience. We have a soft handoff from the emergency department to the MAT clinic. So folks are seen on our next clinic day with a walk-in status. And so we've connected a lot of people actually this way, and many, many of them are still with us in our clinic. So it's been a positive experience engaging people.
So we've talked a lot about substance use disorder and recovery, but what is recovery? So it's important to understand that recovery is more than just being sober or living a life abstinent from alcohol and other drugs. We recognize that perhaps that is one of the most important components of recovery, is having that abstinence, but there are way more contributing factors to substance use disorder than just the use alone. So when we think about genetic factors, trauma in someone's history, social experiences, their own mental health, having co-occurring disorders, these can all be contributing factors to someone's substance use disorder. So those need to be treated and supported as well as the abstinence or being sober. So we recognize that recovery actually gives back what addiction has taken away. When we start to work with someone and we help them with mental health support systems to help with those co-occurring disorders, or we work with someone to get their driver's license back, establish housing, finding a job, reconnecting with loved ones that maybe bridges have been burned because of their use, we are giving them back everything that their substance use disorder has taken away from them. So someone can leave treatment or rehab or the hospital and be, quote, drug-free, but they haven't yet developed the skills or the tools they need for that long-term sustainable recovery. And that's what recovery really is all about. So there are multiple pathways to recovery. As I mentioned, the goal of recovery is more than just abstinence, but it's also meant to achieve a voluntarily maintained lifestyle, which is characterized by sobriety, but also personal health and being a productive member of society. So what each person's journey to recovery and through their recovery can look like will be incredibly different. If there was a one-size-fits-all solution to this problem, we wouldn't have the crisis that we have today. If 28-day treatment programs worked for everyone, then that's what we would do, but they don't. And in part, that's because of the continuum of the disease that Corey mentioned. So if someone has a more mild form of substance use disorder, we don't want to treat them or help them in their recovery the same way we would with someone who has severe substance use disorder. The person on the severe end of the spectrum is going to need more supports than the person on the mild end. So as you'll see on the screen here, we've got on the left-hand side, multiple pathways of recovery for an individual with substance use disorder. And on the right side, we have the family and friends side of things, because we know that substance use does affect more than just the individual, but all of the other lives that they touch, their coworkers, their neighbors, their family and friends. So for some people, they need crisis navigation, meaning they need to get into detox and they do need an inpatient treatment program. For somebody else with maybe a more moderate substance use disorder, intensive outpatient programming or medication-assisted treatment or medication for addiction treatment is what would work for them. Also, maybe on the mild side, someone's got group meetings like Smart Recovery or 12-step or 3-principle. Group supports, that's what they need for their recovery. Some of the things that we offer here at our recovery center are creative recovery, which is art therapy, yoga, meditation, and we will talk more about what peer support coaching looks like, but that's primary support that recovery centers across the state are offering. So it's not just a one selection of these, it could be multiple of these components to help somebody enter into recovery, but it is important to know that each person's pathway will look different. So for family and friends, we provide the same type of one-on-one coaching and support for a family member, because it's important for them to understand what substance use disorder is, how their loved one is struggling, and what they can do to help. So we do workshops where we talk about healthy boundaries. We mentioned that you can't pour from an empty cup. So if a parent is struggling to help their child and they have nothing left to take care of themselves, they're not going to be able to take care of their child when they need them. We talk about helping versus enabling. We do science of addiction training so they understand that it's a disease and how the brain is being affected. We also provide group meetings for family members and friends. And again, they're welcome to participate in things like creative recovery, yoga, or meditation.
So we're going to talk a little bit about why this is so hard in hospital settings. One of the things that we like to acknowledge in our hospital settings is that our staff are really only seeing like this tiny piece of the life of somebody, and they're often seeing it at their very worst, and sometimes they're seeing that tiny piece over and over and over again, and so our staff get really burned out from that, and we know that compassion fatigue is very real, and we know that it's hard for them to see that there's another side or that there's an end to the story. So there's a lot of times we're talking with staff about what happens for people. I spend a lot of time talking to our staff about how people do, like that people get well, recovery works, that people get their lives back and get jobs and do really well in recovery, because they don't really ever get to see that piece of this. And I challenge them too to see that there's a lot of other diseases that folks come in with and they don't have those answers to that either. But we know that when we utilize our resources, we provide positive reinforcement, and we help people with kindness, that we increase their chances of getting well. We had one story at one of the classes that we did that was a security officer. He'd been called down to our emergency department to deal with someone that was being put, I think he was being monitored because he was being dangerous. I'm not even sure what those details were, but it was enough to call security. And in the hour that our security person was down there, he ended up striking a conversation with this person. de-escalated him, which was great, and spent quite a bit of time just talking to him about where he was headed and what he was going to do to start working on some of the problems. And that person today still keeps in touch with the security officer because he went to treatment, engaged in treatment, and is still in recovery today, and gives credit to our security officer for spending the time with him and being kind to him and talking to him about what his plans were. So really, really cool story. And one of the things that we always like to make sure we mention is that when our recovery coaches come into our emergency department or anywhere in our hospital, we encourage our staff to really look at that person and say, you know, most of the time our recovery coaches are people with lived experience, and a lot of the time they've been there themselves, and they're sort of the picture of what can be when people get well. They're gainfully employed, helping other people, getting education. They're doing a lot of really important things in our hospital setting, and it's a great vision, a great picture for our staff to see that people can get well and do great. So we're going to talk a little bit about one sort of case example. These are rough numbers that we came up with from our own hospital. I worked on this with our medical records folks. What we know is that a case of endocarditis, which is, you know, an infection in like a heart valve, can cost us upwards of about $100,000 to $200,000 and even more. And it typically includes a lengthy hospital stay. At least 6 weeks is what we're seeing for most of our folks. And the reason that they're with us for so long is because they need IV antibiotics. Often they need them through a PICC line. Now I'm not a nurse and I'm not very medical, so I use a lot of these terms and I don't always know the answers to what they do, but the PICC line we're afraid to discharge people with because they could use it to inject drugs. And often the endocarditis has come from their substance use disorder, and it happens because for several reasons. Oftentimes we're seeing people that are using either needles that are not clean and they have infectious diseases on them. Those things can travel to the heart and create the endocarditis. It's estimated that there's about 40 to 50,000 new cases per year in the US. The new cases have doubled in the past 2 years. And as you see on the slide, lawmakers estimate that it would cost $45 billion to treat our current drug crisis. So when we made the decision to talk about doing things like medication-assisted treatment through our emergency department, one of the questions that came up, we said, was who's going to pay for the first couple doses of Suboxone? And our hospital administration was great to look at that and say, well, let's look at the numbers. That's going to cost us, you know, what maybe we'll say $20 for one dose, or whatever the cost may be based on what we're giving somebody. That's a far cry from, you know, $250,000 of a typical hospital stay that is significant for something like endocarditis. We cannot ever go back and sort of estimate how many of those we have stopped, but we definitely need to take into consideration that when we give people the treatment that they need and we connect them to treatment services, we may in the long run be saving ourselves a whole lot of money based on medical costs and medical problems that person could have. When we connect someone to MAT, we reduce their hospital stays and their medical costs associated with that. Medication-assisted treatment is generally covered by insurance. When we first started out on this venture, we opened our MAT clinic about 3 years ago, and I remember really wanting to pull my hair out with the insurance companies with prior authorizations and the difficulties that we were having with some of them, and now it's pretty easy. A lot of the insurance companies are doing everything they can to make sure it's covered quickly and that people are covered to come to us and to go to counseling. It's important for us to know that recovery coaching is free. Want to add to that?
Yes, so as a nonprofit recovery center, one of the things that is very important to us is that all of the recovery support services we provide will always be free to our participants. We do intend to, you know, be able to bill Medicaid and some private insurance companies to cover some of those recovery supports, but they will always be free to the participant or the patient.
And then we know that Medicaid and some other private insurers are covering substance use disorder counseling and recovery supports that are of other natures. So there's a lot more coverage out there for people today. And when we keep a patient in the hospital for a big length of time, it's really important for us to know, especially when we look at something like that endocarditis example, 6 weeks in the hospital, I know I would go stir crazy. We know that it's not emotionally supportive for our folks or for anyone, and may not necessarily be beneficial to them in the long haul for their recovery. What we find a lot of the time, quite honestly, is when someone spends 6 weeks in the hospital getting that level of support at the end of the 6 weeks, they're often able to say, well, now I haven't used in 6 weeks and I've got this. Of course, I wouldn't do this to myself again, but then leaves the hospital with really no support. So we make sure that our folks who are in the hospital are also seen by our recovery coaches.
So I mentioned Navigating Recovery as being a recovery center. We are a recovery community organization, or an RCO. And so the partnership between the hospital and us has been important because we provide a lot of the services that are more than what the hospital wants or needs to provide. So primarily, we are a place for someone to start their recovery journey. Oh, there we go. Okay. Sorry about that. So someone can come to us being in what we call a pre-contemplative phase. They're still actively using. They have fear of what withdrawal will be like. They aren't sure if they're ready yet because this is the life that they've known for so long. So they can come to us and just ask questions. We have a lot of resources we can refer them to. And as Corey mentioned, we have recovery coaches with lived experience. That's not to say that every recovery coach is in recovery, but they're either an ally, a friend, a family member, or they do have that personal lived experience. And so the participant who comes to us asking us questions and having that contemplative phase will be met with a judgment-free zone and will feel that they are completely welcome for who they are. So we also host all types of recovery meetings, and on the multiple pathways slide, I had mentioned SMART Recovery, which stands for Self-Management and Recovery Techniques. We also host 12-step meetings. So if you're familiar with AA and NA, which have been long-term 12-step programs, we also host 3 principles and other types of group support meetings because we do support multiple pathways and recognize that one type of meeting isn't going to work for everyone. So we provide peer-to-peer recovery support services, and this is what a recovery coach does. They will sit down one-on-one and mentor the individual. You know, the lack of stigma is there because a lot of times the recovery coach has been where that individual is, and they can say, not only have I been in your shoes, maybe even worse, but I'm now on the other side, and so I'm going to help you work through this and work around all of the barriers that you might face entering into recovery. We have health and wellness workshops. I had mentioned a few of the educational components that we go over with family and friends. We also do other types of workshops for participants on an as-needed basis. If somebody needs help with financial statements or you know, diets and exercise, those are the type of things that we can host as well. We have art therapy, which is the creative recovery program that I mentioned. We also offer yoga and meditation at our center. And we primarily are that resource for individuals and their families as they seek assistance to navigate that journey. There are many barriers that someone will face, and because their substance use has caused the brain disease and the damage that Corey mentioned at the very beginning, it's harder for them to know how to navigate around all of those barriers. And we like to be a safe place for the recovery community to organize and support one another. Unfortunately, because there is a lot of stigma associated with this disease, it's not always a safe place for someone to be out on the streets. So we encourage them to come here and they will be supported in their recovery. So we're grassroots, and I did mention we're nonprofit. So we started off by primarily advocating for people who are affected by substance use disorder. We facilitate access to the recovery resources in our community. We provide that peer-to-peer recovery support. And we also really try hard to participate in the discourse to combat stigma and discrimination. And in doing so, we hope to educate our community. And as I mentioned, we do this all free of charge to our participants. It's very important to us that our services remain affordable by being free. So why do we need recovery community organizations? So We need a place for someone to go when they're ready to start their journey of recovery. Right now, for someone who has struggled with substance disorder and they want to stop, they don't always know where to go. And so if we can get word out that we are the place to start, they can just come here and then we help them with the rest of it. We are here for someone when they're released from the emergency department. That's part of our hospital support program that Corey and I will discuss shortly, and we've already touched on a little bit. But we're also here for people when they are released from a corrections facility. So Navigating Recovery sends recovery coaches into our Belknap County Corrections, and we provide group coaching twice a week for both the men and women in the Correctional Opportunity for Recovery and Education program. And then we have established a relationship with those people so that when they're released from the corrections facility, they know exactly where to come. They've already got friendly faces here, and we've closed that gap as a place where someone can fall through the cracks between starting their recovery and continuing it outside. And as I said, we're also here for family members so that they can come here to learn about their loved one who's suffering from substance disorder and what they're going through. And why we've put the circle with recovery, prevention, intervention, and treatment up there is because although we would love to be able to solve all of these and work in all of these pieces of the puzzle, we focus primarily on the recovery aspect of it. And we often get the question when we do this presentation about why aren't we doing more on the prevention spectrum or intervention? And my response to that is that recovery is prevention for the next generation. So when we can have participants, especially when they're parents, modeling what healthy recovery looks like, that is prevention for future generations. But we can't take it all on. And although we do go into schools and provide recovery outreach, which is a bit of prevention and intervention, there's just more to this, and it's very complex than any one organization can really do all. Okay, so here's more about our hospital support program. As I mentioned, we are on call 24/7 at the hospital. So recovery coaches will respond within 30 minutes once we receive the phone call from the hospital staff. And we do that for any overdose survivor. When we get the phone call and learn that it is an overdose, we will bring Narcan, which is naloxone, the overdose reversal drug, and we give that to them free. We show them how to use it just in case when they leave the hospital, something happens again. We will also go up to the hospital and visit with inpatient individuals who have been identified as having a substance use disorder. So we did a lot of training with hospital staff on how to call us, when to call us, and not to worry about if that patient is going to speak to us or not, to allow us to bridge that. And if they don't want to talk to us, we respect that and leave. But that sometimes it's easier for the patient to talk to someone as a recovery coach because it is more of a soft handoff and there is none of that judgment or stigma. So we started this program back in May of 2017. And since June of that year, we have been up to the hospital to see over 193 different patients. There have been times where we have gone up to see the same patient, but we've seen over 193 different individuals. And as Corey mentioned, we also now link medication-assisted treatment in the emergency department. And that started this year. So since May of 2018, there have been over 15 patients that have been given MAT or Suboxone in the emergency department. And at least 10 or more of those have followed up at the LRG Recovery Clinic.
And I think it's important to mention here too that that when we started this process, that's when we really started to see that our staff needed to better understand what the coaches' roles were. And when we started to look at that, we came up with this whole idea of how do we talk to people and how do we have our staff understand a little bit better about these roles. So we've seen those numbers steadily increase as our staff has become more educated.
So in the very beginning, I mentioned that the work started with a grant from the Foundation for Healthy Communities. And with that grant, they challenged us to include training and education for the needs of the emergency department staff, which is what we have done. They also wanted us to develop protocols to support patients in the emergency department. And that's, part of the medication-assisted treatment being inducted in the emergency department, as well as us working on brochures for staff to hand out and educating staff on when to call the recovery coaches. And they wanted us to develop a longer-term strategy So this is where the uniqueness of having recovery coaches or certified recovery support workers be part of the emergency department, either as an on-call or being placed at the ED on a daily basis, helps the staff really learn about those longer-term strategies. So recovery coaches, although they are recoveries themselves, they are there to help the other person along their path of recovery. And we like to be there before, during, and after, but also instead of treatment. So as I mentioned, with substance use disorder being a continuum, if someone has a more mild, they're on the mild end of the spectrum, they might not need that 28-day treatment or medication-assisted treatment. And so that's where a recovery coach would come in instead of. So it's important to recognize that recovery coaches are non-clinical, but we're there to help remove that personal and environmental obstacle to recovery. We also serve as personal guides and mentors in the management of someone's recovery with their personal life and their family. So we wanted to make sure that this program was well established and also dependable and reliable. So all of the coaches that are assigned to our hospital peer support program have become certified recovery support workers. So what that means is they have met certain educational prerequisites and they've taken an exam. They've had 500 hours of direct client services. They've completed an application and been certified by New Hampshire's License of Drug and Alcohol Use Professionals Board. So those educational prerequisites include a 5-day recovery coach academy. We also require them to do an HIV training, a suicide prevention training, and 16 hours of ethics. And so we really want to make sure that all of the coaches that were going up to the hospital to participate in this program were well educated and well trained. We do recognize that having lived experience is an important part of being a recovery coach sometimes, but there's a difference between just pulling someone off the street who says, here, I know what to do, and having someone who's been trained and educated. In addition to all of that, they've also gone through the hospital HR process. So they're ID'd and badged, so hospital staff can quickly recognize them as the person they called for help. So that is all we have for you today, and we would love to take any questions you have and hopefully provide some answers.
Thank you so much, Daisy and Corey. We didn't get any questions through the chat function, but I think we're a small enough group that if folks do have questions they want to pose verbally now, you could do that. We have a couple minutes to do that.
That'd be great.
And while we're actually, I have a question I'd like to throw out if you don't mind. One of the things I was curious about as I was watching your presentation was, if, at the IDN, we're very invested in integrated care and how partners work together to address needs of clients in the community and enhance folks' outcomes and their recovery process or their primary care process. Could you guys speak a little bit to how you guys might connect to some of the resources in your community for a patient? Like for example, do you refer to community-based recovery coaches after the ED, things like that?
So the recovery coaches that we have as part of the hospital support program work here at Navigating Recovery. So one of our primary interests is getting a recovery coach to link with that patient in the emergency department or anywhere in the hospital and encourage them to come to the center upon their discharge so that we can continue to work with them and make any other community referrals that we need to. But we also work with the social workers in the hospital, especially if someone is inpatient, and help them, as a social worker, make those connections that they need to. Sometimes it's easier to get a person into treatment directly from the hospital. So we recognize that. Does that sort of answer your question, or?
Yeah, I think that's clarifying. Thank you very much.
And I'm going to add to that too. One of the other projects we did under this grant was we developed a brochure, which we know historically isn't always a great thing, a brochure of resources to give to people. But we actually did find that it was really helpful for our staff to feel like they physically had something that they could hand to somebody to say, these are local resources that can help. And we work with all those local resources to make sure that they have, either availability or they know that we're going to utilize them from our emergency department and from our treatment centers to make sure that people have good care in the community. And I just would also add that in our community, we as all of the organizations here have worked really hard to work together to make sure that we're all trying to sort of play nice. There's plenty of business to go around, so to speak. So we're all trying to do what's best for the patient and not what's really best for us as an organization.
And so although the hospital support program was developed outside of the IDN network, or the work that IDN5 has been doing, we have become integrated as part of that as well. So although the hospital and Navigating Recovery's partnership isn't specifically identified in one of the projects of IDN5, it's become part of the other work that we've done just simply through some of the integrated care and care coordinator work that we've been doing in our region.
That's excellent. That's excellent. Thank you for that information. Did anybody else have a question as we move forward? Well, good. If that's if there are no more questions, then I guess I really want to thank Daisy and Corey for their presentation and their time today and helping us kick off our webinar series. I hope there's some really good information provided. Just to throw out there, our next webinar will be near the end of November on risk stratification for enhanced care coordination. It'll be presented by one of our practice transformation practice facilitators, Jill Gregoire. Representing some work she's done here with a couple of different partners, and I think there's an opportunity for some other folks to benefit from that. As it relates to continuing education, you see here the information to obtain that continuing education credit by completing the program evaluation and getting a link to drive you to the credit documentation. That's all facilitated through SurveyMonkey, and you see a link here on the screen. I'll also follow up with an email to the folks who attended today with that link, so you don't have to scribe that down right now. If you don't want to, we'll get that out to you. I hope folks enjoyed the presentation today and got a lot out of it. And if you have any thoughts about future webinar topics, I'd love to hear them. Feel free to send me a note through the normal channels. You can reach out to us. And thanks for your time today, everybody.
Thank you.
Thank you.